Okay, so my name's Ellen O'Connor. I'm a physiotherapist in the renal team at King's College Hospital. I'm originally from Australia, so I've worked in both public health sectors, and today I'm going to talk you through what we do at King's and also just a little bit of the clinical research that we've generated. So, our team at King's is outpatient driven and it sits embedded within a very strong multidisciplinary team. You can see we've got quite a few service streams, such as exercise on dialysis, a renal-specific weight management clinic, a renal rehab exercise program, and also some outpatient clinics. But embedded through each of these is clinical research, and I think that's quite a unique approach. I'm going to talk through our main services and some of the research we've generated, and my colleague, Dr. Greenwood, is going to talk a little bit later about our transplant clinic and also our recent transplant exercise study. If I'm talking too fast, which I do when I'm excited, just give me a wave, please, okay? Right, so just to tell you a little bit about King's, we're based in South London and we have a very ethnically diverse population. We have a significant representation of the African Caribbean population. And I think Roberto reflected on that briefly in his talk earlier today. For our population, we know from the UK renal registry data that at King's, diabetes is a leading cause of kidney failure in our patients. So they already have that comorbid function before we see them. So why intervene with this patient group? Well, we know from the research that kidney transplant participants, in their first year following transplant, they increase their activity, but it doesn't reach the levels of the general population within the first 5 years. Also, kidney transplant recipients are up to 3 times greater risk of cardiovascular disease when compared with the general population. And I think sometimes we can forget this because we're focusing on this area here rather than thinking of the whole person. Also, yesterday's workshop, we talked a bit about the physiology, the effects on exercise and exercise testing. So if you think of a patient, they're a person as a whole, and you need to think about things happening before the transplant. So for example, things like in kidney patients, uremic myopathies. We know we've got effects on the muscles such as fat deposits in the quadriceps from being on dialysis, things like deconditioning. These are all there after transplant. So I think this actually makes them ideal candidates for physical activity and exercise intervention. But before I go into too much detail about what we do, I want to draw your attention to motivational interviewing. And this is a passion of mine. I recently completed my master's in research, and an optional unit I did under the Institute of Psychology was cognitive behavioural therapy. And it's something that we use at each of our clinics in the renal exercise team. And we've kind of touched a little bit already on the past few days about motivation. We've had some great examples of transplants who are so motivated and have done great things by setting goals. So this might be helpful for patients who are not quite there yet in terms of how to improve their exercise or physical activity. So what is it? It's a collaborative conversation between the person and the healthcare professional. And I say person because that patient brings their own experiences, their own knowledge to that situation. It's about encouraging the person's own motivation for change. So what makes that person buzz? What can we key into to help make that change? It's very individualised and patient-focused, and it involves what we call ambivalence. And what we mean by that when we talk about motivational interviewing, or MI, is that ability when we're making any lifestyle change, whether it be cessation of smoking or introducing exercise, we're weighing up the pros and cons. So why are we making that decision? What's in it for me? So ambivalence is about giving that patient the opportunity to have that internal dialogue, weighing it up themselves. Now, righting reflex, what we mean by that is, as healthcare professionals, I think sometimes, or any clinician, we like to tell patients what to do. And I remember as a junior physio, I wanted to tell everyone, you must exercise 5 times a week for 30 minutes at this intensity. But by doing that, we're coming from one standpoint, and we may be taking away that internal dialogue from the patient, and they may naturally take the opposing place. That's not where we want to be. We want to come to that collaboration together to help motivate them. So I've been lucky enough to do quite a bit of training in this area, and our renal team at King's got some intensive workshops with these techniques. With our patients' consent, we recorded some of our clinics and we got feedback on those techniques. So this may be of use. OARS is a very common technique we use in motivational interviewing, and that stands for open-ended questions, affirmations, reflections, and summaries. And I'm just going to run you through an example of each of those. So in my work, I might ask a patient, as an O, what would be different if you exercised more? So I'm giving them the opportunity to weigh up the pros and cons, to consider that decision, and is now the right time to make that change? It may not be. Affirmations is where we key into those patients' values. So they might say to me, well, Ellen, if I exercise more, I may be a bit breathless, and I may be able to play more with my children. So what I'd say to them is I'd say, wow, you really value your family. Your health's important to you. So I'm keying into those patients' values, positivity, and reasons for change. I'm finding out what makes that patient tick, and I'm trying to line up the reason for change with the patient's values. And we all have different values, we all have different motivators, and it's about coming together and working towards those. So reflections, what do I mean by that? That's simply being a parrot, if you like, and feeding back that change talk, those positive words about change, to the patient. So for example, they might just say, if I lost some weight, I might be considered for a transplant. So you might say, okay, so weight loss might help with your goal to get a transplant. And summaries is where, at the end of the discussion with the patient, you're going to give them a brief synopsis of all that change talk. You're going to key it together, and you're going to use the patient's own words, because that's more meaningful to them. So an example might be, at the end of a session, I might say, is it okay if I just summarise what we've talked about today? Feel free to correct me if I've missed anything. If they say yes, I would say, so today you've mentioned to me that you're on the prednisolone and you're finding it really hard with your cravings. You're putting on weight, but you really want to exercise because you want to play with your children and you want to get a bit fitter. So you think that by doing these goals we've talked about, ABC, we can work towards that, and you feel that you're ready to make the change now. And that would just be bringing it all together to move forward. Now, this is a textbook. I know it's a little bit old, but it's quite helpful in looking at motivational interviewing within a healthcare context. So feel free to have a look if you wish. So what do we do at King's apart from just talk about things? Well, exercise on dialysis is one of the services we run at King's. We've been running it for 10 years now, and it's a great way. You've already got that captive audience. They're there for 3 sessions a week, 3 to 4 hours, so why not maximise that time? They can't go anywhere. And also, I think it helps with changing the culture of the unit. So rather than it be a unit of disease or chronic health problems, it can be a unit of health and well-being. So that's one of our participants. They don't always look like that. That's just for YouTube confidentiality. So if I'm going to talk about cycling, I must mention the pedal study. So we know from the research at the moment that there's a myriad of small studies showing various improvements in intradialytic exercise or cycling on dialysis. So the National Institute for Health Research UK put out a commission call asking to address the research question, does exercise on dialysis improve quality of life in haemodialysis patients? And I think that's a really important question to ask. So a research consortium led by King's College Hospital was successful in achieving this and secured the funding, and the pedal study was born. So what is it? It's a multi-region, multi-centred study. It's a randomised controlled trials. There are 5 sites across the whole of the United Kingdom, and there's 380 patients. So not too bad for an exercise study. The exercise participants have 9 months of cycling with a 15-month follow-up period. And there's also some sub-studies looking into outcomes such as body composition and heart rate variability. But what I want to draw your attention to is our Monarch bike. We're quite proud of it at King's. And I know Charlene had quite a few teleconferences to get the bike how we wanted. So from doing cycling for the past 10 years, we've used various models. We knew what worked, we knew what didn't work, and we kind of had a rough idea of what we needed. And this is what we've come up with. So you can see at the top, it's actually a proper spin bike. So in the past, we've had, arm crank machines, so little arm things, having them welded on to attach the dialysis couches. So that's a manual handling risk for staff. We wanted something that could be freestanding, which this is. We wanted something that the staff member could just wheel to the patient and use, so you didn't have to pick it up, you didn't have to put it on a trolley and wheel it to the couch. And we wanted something, most importantly, that could be used on any dialysis couch or any dialysis bed. We've had issues in the past where we've had a specific bike, the units decide to change their couches. We can't use those exercise bikes anymore. So that was really important for us. Another consideration was size. So we're based in London. It's very population dense. This bike can actually hinge from here to adjust it to the patient and also for packing away. So we don't yet have any results to share with you because the trial's ongoing, but watch this space. Hopefully we get the results we're after. So when looking at any cycling program, you need to think about what patients are appropriate. So looking at things like intradialytic weight gain, blood pressure, blood sugar levels and all those things. And also who's going to lead the program. We know in the UK that physio-led programs seem to work better than the nurse-led programs, and I think that's just due to the staff barrier of time. So often the nurses have so many observations they have to record, they have to weigh the patients pre and post for the dialysis, that by having an exercise champion staff member, they can see it more as an intervention, part of the patient's care, rather than an adjunct. And also things like patient barriers. So I don't know if anyone's come across the dialysis patients. Our patients are getting older. They might not feel that they can participate in exercise. So cycling is a great thing because they can see one of the other patients cycling and they might go, oh, can I have a go at that? Even if they just start with 2 minutes and then build up gradually, they can get quite good results and they can feel quite motivated in the end. And this is just a pragmatic guide that we created a few years ago looking at setting up cycling programs. So our weight management clinic at King's is a 3-facet approach. We use a combination of individualised low-fat diets, an individual exercise plan, plus or minus orlistat, which is a lipase inhibitor and safe to use because our patients have a lot of polypharmacy. So why do we do weight management at King's? Well, I think we heard this morning about weight gain and it's very significant in the first year following transplant. We also know from the research that exercise alone does not improve weight loss in kidney transplants. It needs to be that multifaceted approach. And our team at King's, at the bottom here, have published some papers looking at this clinic, and we've shown significant weight loss and improvement in functional outcome measures, such as sit to stand, 60, incremental shuttle walk test, and some questionnaires after 12 months. And these improvements have been maintained at 2 years. This morning's discussion, we were talking about donors. We've had donors in our clinic as well, and we've also had patients accepted onto the list. We even had one clinic where the transplant coordinator ran into the room and our patient literally went to have a transplant, so that was really nice. So the team consists of a senior physiotherapist specialising in renal, and the same for a dietitian. We have a physiotherapist assistant and also a nephrologist if we need that orlistat prescription. Motivational interviewing is key in this clinic, and we use what we call a buy-in approach. And what we mean by that, I think Charlene touched on it briefly. So patients who fit our criteria, a BMI above 30 who want to lose weight, get sent an invitation to come to a group education session where we present what we do in clinic. And then we give everyone in the group a 7-day food and activity diary with a prepaid self-addressed envelope. And we kind of talk about we end the discussion with, is now the right time to make this change and so forth. So linking in with the stages of change theory. And those that send in their food diaries get booked in a clinic appointment with the physio, the dietitian and the patient, so those 3 problem solvers together. So that way, it's quite labour-intensive motivational interviewing when you first start doing it. It can make clinics run a little bit longer, so you want the patients who are actually wanting to make the change, so that's why we call it buy-in. And it's very individualised. So each session, the patient has some food and some activity goals that they're going to work towards. So this is just some examples, some of the resources we use. We look at simple, obviously this is a dietitian, looking at things like healthy plates, so increasing fruit and veg to decrease fat content, and also things like portion control and so forth. So we have lots of good resources to use. And this always, you do learn, I can't have spaghetti bolognese and garlic bread anymore, and things like pastries because of what I know now. In terms of my point of view, so activity resources we use, we have a renal specific exercise diary. We talked about smartphones, so a lot of them have built-in step counters. I really like MyFitnessPal because it charts your food intake and your exercise output, so it's that energy balance. And there's an NHS app which I find quite helpful called Couch to 5K. It's a 12-week program starting from a couch potato to being able to run 5K. And you can individualise it as you need it for your patients. And most of all, what does a person actually want to do to help pick the best tool for them? So this is our renal rehab poster. It's displayed in all our outpatient clinic waiting rooms and also our dialysis units at King's. And we've had various patient champions. And I think the nice thing about our program is that, obviously I'm biased, is that patients can move in between it. So they might start in the weight management clinic and then they might come to the renal exercise class and then they might get transplanted and here we're doing an exercise study and then they might take part. So we have quite a nice relationship with our patients. Any patient across the renal trajectory or donor, so pre-dialysis, dialysis, PD, transplant, can come along and self-refer, or they can be referred by any member of our team. And we get quite a few patients coming from far away just to join in with us. So what do? It's 12 weeks, twice a week, exercise as well as a group education session that we've tailored to what the patients want to learn about. So we questionnaire them and so forth. We use those MI principles to help set goals and also to problem solve barriers towards exercise as well. We do a combination of aerobic and resistance training, and our transplant participants are more than 6 weeks after transplant. And Charlene did a paper in 2012 and we showed across all renal patients in the program a significant pre-post functional outcome improvement. And if you look at just the transplant subgroup, you see significant improvements in incremental shuttle walk test, stair ascend test, where you get them to walk up 1 flight of stairs and down and time it, and also the Duke's Activity Status Index, which Charlene will talk to you about a little bit later. So this is just an example of one of our goal-setting worksheets we do with the patients. So yesterday we talked briefly about goals, and our motivated patient champions from yesterday talked about making them specific. So SMART goals, has anyone come across them before? Yeah, one. So they're specific, measurable, achievable, realistic and timed. So in the group education, we talk through what that means. We generate examples as a group, and then the patient takes this home, hopefully fills it in, hopefully remembers to bring it in. And then what we do in their next exercise session, we make sure that their exercise program is actually meeting along with this, because otherwise we're just exercising for the sake of it. We want to make sure that the patients are achieving what goals they want to. So they find this quite helpful for directing their exercise. And the transplant clinic, Charlene will talk more about this, so I'll just touch on it. We see patients as part of their annual review. So they have what we call an MOT, or full body check. They come and see us, we talk about what they're doing, we set individual physical activity and also exercise plans. We can link them into our other services I've told you about. But also, because we're a specialty renal service, we get patients coming from all wide. I've got a patient from Brighton, believe it or not, coming to see us in the transplant clinic. So what we've started to develop over the years is linking in with community gyms and exercise programs and ensuring that they will accept renal patients. We've had a lot of issues in the UK over the past few years where renal patients for insurance purposes weren't accepted to gyms. So now we've been liaising with local gyms and getting them on board to take those patients. And we've also got the EXERT study, which is an exercise in renal transplant study. Charlene will speak about on Friday. Yep. So in summary, I think that King's, we have a unique perspective of partnering clinical practice with clinical research. We find motivational interviewing very useful to help patients engage with physical activity and exercise. We've shown significant improvements in weight management and also functional outcomes across the CKD trajectory, which could be, and I say could because it's a research world, be suggestive of improvements in cardiovascular disease and cardiovascular risk, which we know are important in this patient group. And we have quite a keen interest in translational research as well. So I'd just like to say thank you for your time. It's been appreciated, and thank you for the opportunity to present today. And I will leave you with a slide of myself and Charlene practicing what we preach at the UK Kidney Research Fund run at a UK conference a few weeks ago. Thank you very much.